My name is Eve Fields. I'm a psychiatrist. I've recently worked at the Department of Mental Health and other organizations, but have been involved in tobacco work through the Department of Mental Health in my role as an integrated care psychiatrist.
Hello, my name is Dr. Amanda Palmer, and I am faculty in the Department of Public Health Sciences at the Medical University of South Carolina, and I also work in the Hollings Cancer Center.
Hey everyone, my name is Lorenzo McCray. I work for RVO Health. We are the vendor who manages the South Carolina Tobacco Quitline, along with the Live Vape Free program. I've been with RVO for almost 9 years now. If you were here last year, you might remember I spoke with the Health Systems Optimization Program. We did outreach within the state. Since have taken a different position, but glad to be here again.
Good morning, everyone. I'm Sharon Biggers. I am with the National Association of Chronic Disease Directors and formerly with the State Tobacco Control Program with Department of Public Health in South Carolina. So it's great to see everyone. So I'm going to start first. I don't have any slides, so I will go ahead and get the panel started. As I mentioned just a second ago, I'm Sharon Biggers. I'm with the National Association of Chronic Disease Directors, and I'm excited to talk to everyone today about novel and innovative treatment. My focus is going to be specifically on state tobacco control program work across the country. I manage a tobacco cessation grant with NACDD, and we work to support health systems change and increasing insurance coverage for tobacco cessation services. So I'm very excited to be back in South Carolina talking about this great work. I want to start off by sharing some information, and Andrew mentioned it a little bit earlier in his presentation, and this is information that has been compiled by our partners at the North American Quitline Consortium, but just wanted to begin by acknowledging the ongoing uncertainty that's surrounding the federal administration's proposed restructuring of the CDC and the potential implications for both state and national tobacco control programs. We are gradually learning more about what these changes mean, including the impact of the recent reductions in force, or RIFs, at CDC's Office on Smoking and Health. Much remains unclear, particularly regarding the future of state tobacco control programs. We're closely monitoring things at the federal level to try to better understand how these programs may be affected. But just to kind of drill it down, the Office on Smoking and Health funds all 50 states and all territories for tobacco control program. It's part of the National Tobacco Control Program. And so states get funding from Office on Smoking and Health to support their state tobacco control programs. And in addition, they also get a significant portion of their funding for their state Quitline services. So the impact on Office on Smoking and Health and the funding that comes down to the states is quite significant, and it's something that we all need to really keep an eye on and understand as things begin to unfold. So at NACDD, we remain committed to supporting states as they implement their work plans, adapt to emerging challenges, and sustaining tobacco cessation efforts through this period of transition. Fortunately, many states, and South Carolina is among them, receive funding beyond just the CDC allocations. So that includes funding from tobacco settlement dollars, from state tobacco or cigarette taxes, from dual settlement funds, or even just general appropriations from their legislatures. So these diversified funding streams really underscore the importance of sustainability planning within state tobacco control programs, and as is part of the state tobacco plan that was developed for South Carolina, the 5-year state tobacco plan. So sustainability is extremely important, and I encourage everyone to really take a look at that plan and look at the sustainability efforts that were included in there and really emphasize that. We continue to emphasize at NACDD using best practices for cessation, such as building and maintaining health system partnerships and expanding insurance coverage for cessation services. Using this framework ensures sustainability efforts are grounded in proven strategies that lead to meaningful outcomes. Now, with that said, I'm going to talk a little bit about some of the great state work that's been going on that's innovative or novel for cessation programs. And I will start by pointing out that South Carolina does really have a gold standard cessation program. Everything that they do is fantastic in this space. And I'm very excited to enhance a little bit of information that might be helpful as programs move forward. It really exemplifies how strong infrastructure and policy alignment can drive long-term impact. So across the country, states are implementing innovative approaches, and primarily it's to expand access to cessation services. So please keep in mind that the things that I mentioned, it remains to be seen how the funding changes at the federal level will impact them going forward, but these are things that I know about as of today that are going on. So there's a real emphasis across the country on rural health care. In particular, there are 2 states that are doing some great work, Ohio and Indiana, and I'll mention Indiana's program because it's a little more developed. Indiana has a program called I Hope Initiative, and they partner with rural healthcare providers to build their capacity to deliver free cessation programs within their facilities and their settings. And it also includes the use of carbon monoxide monitors like the Smokalizer. If y'all are familiar with the Smokalizer, I know a lot of programs use that. And that provides the real-time biofeedback for the patients, and it really helps the participants visualize their progress. So really working with rural healthcare to integrate cessation services within their programs. I'll also mention another thing that we're seeing trending across the country is an emphasis on addressing tobacco use among pregnant tobacco users. So in addition to the 11 states that implement the Baby and Me Tobacco Free program, which is the program that South Carolina implements, I want to mention 3, Oregon, Wisconsin, and Connecticut are doing some great things in this space. They are investing in comprehensive cessation programs for pregnant tobacco users, implementing behavioral counseling, tailored support, and both financial and non-financial incentives. So example of non-financial would be like diapers or wipes or other baby products, car seats, things like that. And they are especially emphasizing this work with Medicaid enrolled individuals. North Carolina's program is called You Quit to Quit, and it's focused on integrating cessation support into routine prenatal care. So really integrating the cessation throughout the prenatal care period to really strengthen the services provided to the pregnant tobacco user. Another thing that we're seeing is, in addition, is increased access to support. There's a program in Pennsylvania where the Department of Health there manages what they call the Pre-Approved Tobacco Cessation Registry. And that offers a vetted list of trained providers and services accessible statewide. And this ensures consistent, high-quality support for those trying to quit. So in these states, they all maintain state Quitlines, and they all do the referral to Quitlines, but we're seeing more of an emphasis on integrating cessation into these settings so that it's not just the referral out to services, but the internal referral to services to be able to provide those to their clients and patients. Finally, I'll finish up with a holistic approach that's going on in California. And of course, California is one of the landmark programs in the country. They're very well funded, and they have been providing a lot of the evidence base for tobacco control across the country for many, many years. Their program is called Advancing Tobacco Cessation in Community Clinics. And the Department of Public Health in California funds federally qualified healthcare centers, FQHCs, to enhance the services for underserved communities. This includes evidence-based quality improvement efforts, improved data monitoring, tobacco-free campus policies, so it's always important to include those tobacco-free campus policies along with cessation to help enhance cessation and to provide tobacco-free lifestyle observation. And they also integrate cessation within a whole person wellness approach. So they add things like stress management, healthy living, nutrition services. So really looking holistically at the patient and not just addressing the tobacco use, but also addressing the social determinants that are around that tobacco user to try to impact and help them have a more successful quit. So as I close here, I want to say that as states adapt to evolving landscapes, time will reveal what adjustments are going to be needed. My organization, NACDD, will continue to be a resource and a partner to programs nationwide, helping them navigate the changes and sustain their impact. But I also want to emphasize that tobacco control advocates and folks that work in this field are very flexible, very creative, and very resilient. So I'm sure that we will find ways to adapt and to adjust, and we will continue to support tobacco control, tobacco cessation, tobacco prevention, because we know it's the right thing to do, and we know it will help prevent chronic diseases and help control chronic diseases into the future. So I just want to encourage everyone, even though the news is sad and it's hard to hear and it's scary in some situations, I just want to encourage everyone to remain resilient, to remain creative, and to remain flexible, and we will continue to succeed together. Thank you.
Good morning, everyone. Can you hear me? Oh, can't tell. I've never spoken to a mic before. But yeah, my name is Lorenzo McCray. I'm the Client Services Manager with RVO Health. And I just want to touch on a couple things that Sharon, our first speaker, touched on. It's been really hard these last, I say about a month now, with the whole CDC fiasco. We manage about 23, 24 states. I'm in the southeastern region, so I have South Carolina, Georgia, and Florida. And we've just seen a lot of states have to roll back services, like through their quit lines. For example, my Georgia clients, they're all being laid off. So next week is their last week. And it's just hard because, you build a relationship with these people. And then to get that news and not have scheduled meetings anymore, it's been really tough to see what they're going through. So just want to reiterate, you guys are very important. What you do is important. So keep it up, and hopefully things will get better. We'll see the light at the end of the tunnel. And also, I want to brag on us a little bit. Here in South Carolina, she kind of touched on that South Carolina is a gold standard when it comes to tobacco cessation services. And we're graded very highly on that. And throughout of our states, we have a tier 1 state here in South Carolina, which is important. So we're not always at the top of the list with stuff. So whenever we are, I think we should brag a little bit. So there we go. But today, my focus is on basically the Quitline, the specialty tracks that are available to kind of reach different demographics within our state. So I'll start. So, hold on. Yeah. So what is the Quitline? So it's a free tobacco resource here in South Carolina. I always like to reiterate, it's free for anybody ages 13 or older. They just have to be a South Carolina resident. But the Quitline offers integrated telephone, text, and chat web-based services to support participants who are wanting to quit commercial tobacco and nicotine products. And we use the term commercial because we'll get into it later, but the American Indian population, they refer to as traditional tobacco use, so we always want to use those terms correctly. But basically, you have to meet people where they are. Some people like telephone, some people would rather text, some people would rather just have the digital platform. So we really try to, meet people where they are and tailor the program to that individual specifically. We engage in local, state, national, different conferences, and we go to a lot of community events. I'd like to give a shout out to our Health Systems Optimization Program team, who I was a part of up until August. So they do great work, but they go to they're the boots on the ground who go to doctors' offices to promote the program, community events, conferences, and like I said, local or national. To really get the word out, because we'll go into doctors' offices and I may have seen the 1-800-QUIT-NOW commercials, but I don't know much about the program, so their work is highly valuable. We'll see our conversion rates skyrocket because people can actually be educated on the program and accept services. So kudos to y'all. And then we're committed to helping all participants through evidence-based treatment, coaching, and the nicotine replacement therapy medications, which are free. Web support, but in my opinion, the coaching is one of the most important parts. Our quit coaches are highly trained. They have quarterly trainings that they have to complete, and just that personable approach, really talking to participants and coaching them through those coping mechanisms and urges they may have to get them to make it to their quit date. This is a snapshot of the member journey once they're enrolled. So during enrollment, they can call in by the phone, you can go on web, you can text READY to that number 34191, or of course we have our Spanish services as well, or you can be referred through a physician or whoever may refer you to the Quitline. There's several ways. But once you're enrolled, you go through the program stratification. They kind of put you in a specialty track, which I'll talk about here shortly. So we have our youth program, our pregnancy program, behavioral health, which is very important, American Indian, and then standard program if you don't fall into any of those other categories. Then we collect a lot of data. Obviously, we love data. We just want to find out the prevalence within the state and different demographics and all that information. And then you jump right into a coaching session, so you get linked up with a coach. You get at least 5 sessions, unless you're in the youth program, but I'll go over that in just a minute. You have ongoing milestones on your dashboard, so they always want to encourage you. They may nudge you if you're not going through your program at the correct pace, or maybe you haven't enlisted to get your free NRT, whatever it may be, so they want to keep up with you. And then, of course, hopefully, it's ultimately their goal, but you have to make it to your quit date. Now, once you're done, once you met your quit date, we're not just stopping services. You still have access to your digital platform. And, of course, not everybody can quit the first time. We understand that. I think they say it takes maybe up to 7 times to quit. So we have our re-engagement campaign, which re-engages with participants, and re-enrollment. You can enroll twice within a year. So we'll keep up with them. We don't just cut them off. When as much services they need, that's what they're going to get. This is just a screenshot of our dashboard. We're on a digital platform called Rally. Basically, it has all their profile, their settings. Like I said, it's tailored to that individual specifically. They can chat with a coach. They can manage their NRT. They can even track it to see when it's going to be delivered to their home. Of course, one of the most important parts is making sure their dose is correct, because a lot of people will just go buy gum or a patch, slap it on, and think that's what they need. No, sometimes you need combo therapy, so they want to make sure you get the correct dosing and get everything that you need. Different messages, like I said, to nudge you a bit or keep up with you, to encourage you. You have a library of different multimedia stuff you can watch. And then clear calls to action. Get rid of your ashtrays. If you need a cigarette after breakfast, let's cut that out, like mini quits throughout your program. I included this. This is just a reference point that I use to kind of show the services that are offered within the South Carolina Tobacco Quitline. So again, there's different specialty tracks. So depending on which program you're in, we'll kind of bounce off into how many coaching sessions that you may be eligible for. If you're eligible for nicotine replacement therapy medications, the offering that you're eligible for, and the amount. So this is just kind of a reference point I like to share. Kind of keeps us true and make sure that every participant gets exactly what they need and what's in the contract. So we'll talk about that in just a second. So I'll touch on just a high-level view of our specialty tracks in the interest of time. So we'll start with our youth digital track. So it's called the digital track because they don't have scheduled coaching calls anymore. They originally did. They had their 5 calls, but we noticed that age group, ages 13 through 17, they're just not going to engage with a quit coach. Sometimes they don't want their parents to know. They may be afraid of that, but it's a great program. They have different milestones and online courses that they have to complete. There's 6 of them. So we generally say it takes about 6 weeks to complete, a week for each course. Sometimes they lag a little bit, their minds are all over the place at that age. So about 6 to 8 weeks to complete. And the participants, they don't have scheduled coaching calls, like I said, but they can always call or chat with a coach on the digital dashboard. So they may have questions or concerns. And we don't want to just say you don't have availability to a coach. At any time, 24/7 coaches are available, so they can chat, like I said, on the digital platform or call in, and they do have access to whatever questions they may have. And then once they complete those 6 online courses, they get what's called a letter of completion. It's on their dashboard. It pops up. Of course, we give them their kudos, congratulations. They can download that letter of completion, email it to themselves, and if they need to send it to somebody like a school representative or a parent or guardian, And our goal really is to use this as an alternative to suspension program. We don't get a lot of traction through the Quitline with youth. They're more so going into our Live Vape Free program, which makes sense. Cigarettes, commercial tobacco use is kind of down within our teens, but vaping has skyrocketed, and now Zen and all this other stuff. So, and the tobacco industry, they do such a great job of targeting the youth, all these different flavors and all these cool digital stuff that he showed I didn't even know about until now. So it's just amazing, that's why they spend billions and billions on marketing. So we just, want to promote this as, hey, instead of suspending these kids so they can just go get another vape and come back to school, let's make them complete this program or a Live Vape Free program and show that they're really getting the education on why tobacco use is bad for them. They even go into the development of the brain and different habits, or why, if they play sports, how it could affect that, all that kind of stuff. So very good job with the Quitline, just keeping up with our youth within the state. And they're not eligible for nicotine replacement therapy medications just due to their age. So if they do want to pursue that, it has to be through a physician. All right, so another important track that we have is the pregnancy and postpartum. Obviously, there's a lot more information now on second and third hand smoke, which is huge, especially postpartum. It's like, all right, I'm not pregnant anymore. Maybe I can walk outside and smoke a cigarette. No, you track it back in the house, and that's why that information is good. So our coaches really hone in on that type of stuff. So with NRT, they're not eligible for NRT through the Quitline, but they do encourage it by going to a physician and getting your correct dose. Like, they really rely and defer to their physicians, because it's really not a decision that we want to make through the Quitline, just because of intricacies with pregnancy and all that kind of stuff. So once that is approved through the provider, we can still coach them on the correct times to use your NRT, give them little nudges and stuff like that. They get extra coaching support. So with our standard program, generally you get 5 sessions that are scheduled. Well, they get an extra 2. Obviously their program may be a little bit longer. We want to keep up with them after or during postpartum. So yeah, those 2 extra calls are really helpful. They're not always utilized. Obviously it's up to them to really stick to the program, but we want to offer that just to stay with them. And then at the bottom it says, specialized coaching. Participants receive personalized coaching from highly skilled. Like I said, they go through a lot of training to be able to speak, give them education and speak eloquently to these participants about the different, effects of smoking while pregnant, how it can affect the baby. They have different action cards and stuff that they can read about on the digital platform that kind of gives them extra motivation. Like, hey, it's not just about you anymore. Let's do this for you and your child. But the effects of smoking on pregnancy, benefits of quitting, so get them really thinking critically, like, if I do quit, how is this going to help me and my child? And then, of course, relapse prevention postpartum, which is probably one of the most important pieces. All right. And the American Indian track. So like I said, we're really specific about the terminology we use. Specifically, this demographic, they have a lot of tribes have traditional tobacco use that kind of, morphs into commercial tobacco use. I mean, it's an addictive, substance. So our coaches, we have a team of American Indian quit coaches and non-American Indian quit coaches that go through trainings to really be able to earn that trust, because if you don't earn that trust with that demographic, they're just not going to engage, they're not going to enroll, so that's a very important piece. They also get 2 additional quit calls. We think that's important to really stick with them. And once you earn that trust and you have that personable approach, they really open up, and that's, I think, one of the best options that we have is the coaching. Of course, they're eligible for 12 weeks of NRT. That's just a very vulnerable demographic. We don't have a large demographic here in the state of South Carolina, but we still think it's important to offer this track. So they get 12 weeks of NRT, and that's one of the key points about South Carolina too is, now that I've learned more about other state quit lines, most have like a 4-week NRT limit. South Carolina, we offer 12 weeks for several, demographic of participants, and they come in 4x4x4 shipments, so 4-week shipments. So that's one thing I always like to tout and brag about is South Carolina does a very good job on providing those services for these participants. So kudos to us. And one of the most important, if not the most important, health track that we have is a behavioral health track. Just that first bullet point there just tells you everything. It says, of commercial tobacco users who call, quit services, and enroll, nearly 45% have at least one behavioral health diagnosis. So I think we've done a really good job in this nation on focusing on behavioral health and mental health. I'd say over the last 10 plus years, really focusing on that. Before, suck it up, you'll be fine. But we know psychologically, biologically, like it's not that easy. And it's harder for this demographic to quit. So when they enroll, they have a series of questions like, have you been diagnosed with behavioral health diagnosis? And if they do answer yes, the next set of enrollment questions, they get a whole list of different things they can check off. So that lets our quit coaches know, okay, we need to provide them with some information on how tobacco may affect this diagnosis. We need to let them know if there's other substance abuse, like quit everything at once. Like, let's really tackle this. We understand it may be harder for you to quit, and just get them out of their habits and everything, and just give them the best option to be successful and sustain a quit. So they get extra coaching support as well. They get 7 quit calls, so 2 on top of the 5 base program calls. And so our coaches, like I said, quarterly go through different trainings, and a lot of our coaches have experience with nicotine use, maybe behavioral health diagnosis, so they can build that, personal relationship with these participants. And that's one thing I think is a really good piece to our program. So we just make sure we provide, like I said, quick kits and action cards on their dashboard that tailor and tell them why, tobacco may affect whatever behavioral health diagnosis they have, or why it's important for them to quit. And it's just that digital dashboard is invaluable because they can go on there, get different nudges, see different action cards, and get information that they have that's important to them in their quit journey. And that's all I have. There's my nice little picture. Thank you all. That's my information. If you have any questions, just reach out. I'll be glad to answer any questions. Just let me know. Thank you all.
Hello, good morning, and thank you all for having me today. I think I'll start by echoing our previous sentiments here that we're in some really difficult times right now, and I think it's great that we're all still here coming together and really trying to move forward despite some of the barriers that we have going on. So I am here to tell you today about a new drug that we may be seeing come up in the United States right now called Cytisine. And this would be a new pharmacotherapy to treat tobacco use, so it's really exciting. So cytisine is a naturally derived compound, so it actually comes from this plant that you see here. And cytisine is, it's been available in Eastern Europe for quite some time now. So Bulgaria specifically, this has been around since the 1960s. And it's been used as a smoking cessation treatment and sort of marketed as this natural plant-based supplement to help people quit smoking. Again, being marketed as natural and plant-based is really appealing to a lot of people, people that, maybe are, more resistant to taking medications, but also there's been some work done with certain indigenous populations. For example, the Maori populations in New Zealand. They really like that this medication comes from a plant and comes from a natural source. So this could be really appealing to some people who otherwise maybe wouldn't take other forms of pharmacotherapy. And so this compound looks a lot like varenicline or Chantix, which you may all be familiar with. Essentially, it's a partial agonist that binds to the nicotine receptors in the brain. So it looks very similar and it acts very similar. Cytisine doesn't bond quite as strong as varenicline does, but it's got a really similar mechanism there. And the way that a partial agonist works is twofold in helping people to quit smoking. So again, this applies to varenicline and also to cytisine. On one hand, it binds to the receptors, and so that can reduce nicotine withdrawal symptoms. So you're sort of mimicking getting that nicotine, and it reduces withdrawal. But the other thing that it does is it blocks the receptors. which means that when you are using a nicotine or tobacco product, or again, anything that contains nicotine, it's going to block those receptors, which releases less dopamine. Dopamine is our reward chemical in the brain. So essentially, it makes smoking and vaping feel less rewarding. So if you've ever had a patient that said, I wish there was a magic pill that just made me not like smoking anymore, we've got one. And hopefully we'll have two coming up later on. And so, again, this has been around for a very long time, but it's sort of taken a while for it to really, expand outside of Eastern Europe. There's been some research on this, and, there's a lot of reasons why, regulatory-wise, why this may have taken a long time. But I just wanted to, give you a sense that there's been a lot of international research going on in this space. Again, in Switzerland, there was a review that was done of some of the smaller studies that had been done, again, in Eastern Europe. In the UK in 2011, there was a large placebo-controlled trial that showed some pretty good results. In 2014, there was a trial in New Zealand that compared cytisine to nicotine replacement therapy, and we saw that cytisine actually worked better than the nicotine replacement therapy in that study. Okay. After that, there was another trial that was done in Australia comparing cytisine to varenicline. You can see in all the way on the right there that the results were pretty similar, although cytisine didn't seem to have as robust of an effect as varenicline. And that kind of makes sense. Again, it doesn't have as strong of a bond, but that was just, some important information to know. And so what's going on in the U.S.? So there is a pharmaceutical company called Achieve Life Sciences that is working on developing a cytisine drug called cytisine, I think. not a pharmacist here. But essentially, their goal is to go through the full FDA process to have this be a new drug. And they recently also received what's called a breakthrough therapy designation for cytisine for e-cigarette cessation as well. So again, we're really in the process of this happening, and hopefully by this summer, we're going to start to see some more movement here. And so there's been a series of trials that have been done by Achieve Life Sciences. They have a really fun acronym, the ORCA trials. And these have been primarily led by Dr. Nancy Rigotti. She is a physician at Harvard who has done a lot of work in the tobacco cessation space, so really prolific researcher who has been working closely. And as you can see, again, a lot goes into drug development, especially in the United States. And so several trials have been done. The first one was to get a sense about what the best dosing schedule would be for a drug like this. Again, the way that it's been used in Eastern Europe kind of varies based on how you're getting it and what country we're in. So we wanted to establish what would be an effective dosing schedule. We then evaluated a single dose for 2 different treatment period lengths. So for 6 weeks and for 12 weeks. They then evaluated that single dose for e-cigarette cessation. And then finally, the most recent trial that came out replicated one of the previous trials, but collected more safety data, which again is going to be very important for FDA approval. So I'm just going to briefly go through some of these results for you so you can see what's been happening. So again, in the ORCA-2 study, which was where we were testing a single dose for both 6 weeks and 12 weeks compared to a placebo, you can see all the way on the right that both 6 and 12 weeks had better outcomes than the placebo. In this graph here, you can see, again, we've got our 12-week treatment period is going to be in the dark blue lines, our 6-week is in the orange lines, and our placebo is in the light blue lines here. 12 weeks did appear to have a little bit of a better outcomes throughout the course of treatment than 6 weeks, and you can sort of see at that 6-week mark where things switch. So people who take the medication for 6 weeks do pretty well. Things tend to fall off a little bit after that, whereas if you're taking it for 12 weeks, you tend to stay on the course a little bit better. So that's important data to know there, that staying on this medication for longer seems to have better outcomes. And that's true for a lot of the medications that we use for smoking cessation. In ORCA 3, again, they replicated this trial and they also collected more safety data. So again, if you look on the right, you can see here that, again, in both the 6 and 12-week treatment courses, there were better outcomes than in the placebo. The 12-week did look a little bit better than the 6-week. But the important aspect here for this study that we were looking at was the safety data. And so these are some of the adverse effects that were reported for the placebo, 6-week, and 12-week treatment groups. So there were some adverse effects reported. I will say that compared to varenicline or Chantix, these are lower, there's lower prevalence of these adverse events. So we tend to have fewer side effects with this medication compared to varenicline. And again, nothing significant or substantial enough to say that this would be an unsafe drug to give people. In the study where they were looking at cytisine for e-cigarette cessation, you can see all the way on the right, again, drug versus placebo. The drug tended to have a good effect there. Again, these are graphs that show over time. On the left, it's going to be the proportion of people who were abstinent over time, with the orange line being those who received cytisine. Again, they tended to do better than the placebo group over time. On the right, you'll see saliva cotinine results. So that's a measure of nicotine exposure. It's basically, just getting a biological confirmation that people had indeed quit vaping in this. So you'll see the orange line with the dots is going to show our mean cotinine results, and that's going to be lower for the cytisine group. But what's really interesting is if you look at those diamonds on the bottom, that is the median. So going back to our math classes, right, if you kind of take all of our results and line them up in numerical order, the median is going to be what number's in the middle, and that is 0 for the cytisine. So what that's saying is most people had a cotinine reading of a 0. So most people had 0 nicotine exposure. There were a few that were kind of driving up that mean in terms of those who maybe weren't able to achieve full abstinence by that point. So again, really, really great results that we're seeing here. And so, what this might look like in terms of how this would be prescribed. Right now, they are, considering having the prescription ages being 18 to 65. That's probably because we just haven't done enough research on those younger or older age groups yet. Same for pregnant or breastfeeding women. It's a similar recommendation for varenicline. We don't typically recommend it for that population. There's probably just no data for cytisine within that group, and so that's just something to be mindful of there. And similar to varenicline, there are certain cardiovascular and endocrine disorders, again, really significant uncontrolled disorders that we would not recommend this medication for because of the potential for some complications. The way that you would take this medication, again, is going to be very similar to varenicline. So what we do is we tell people to start this medication while they're still smoking or while they're still vaping. Again, if you remember, while you're taking this medication, it reduces that rewarding sensation. So it helps your brain to learn that smoking and vaping is going to be less rewarding. So you want to, continue to smoke and vape for that first week while you're taking this medication and while you're tapering up on the dose. They've found through these studies that immediately starting at a high dose is going to increase the side effects. That's going to make people stop taking the medication, and that's just not going to work. So we taper up on the dose here. Once people have been taking it for a week, we ask them within a week or so to plan a quit day and make that quit attempt, and then continue taking the medication. Again, we've seen from the studies that I just presented that a longer treatment course is going to be most effective. So we want to encourage people to stay on this medication as long as they're able to tolerate and as long as they feel like they need it to support their quit attempt. The big question that we have is how much is this going to cost people? We know that in the U.S., especially with new prescription drugs, there can be the cost can be very prohibitive for people. And I understand that these companies, again, have already put in a lot of research and are going to continue putting in a lot of research, and they need that return on investment there. And at the same time, this is a drug that is supposed to be helping people and potentially helping some of our most vulnerable people who might be, economically disadvantaged. You'll see in Bulgaria, it is very inexpensive there, and that's because it's produced locally. I've actually had patients in the US report that through, I don't know where they are on the internet, but somewhere on the internet they've been able to buy it, and they actually describe it as, it's a plant-based supplement that helps me quit smoking, and they describe it as actually a Suboxone for smoking cessation. So that's kind of an interesting way to think about it. But again, there are some people in the US that are getting it. In Canada, for example, their version of Cytisine that's available is actually sold as a health supplement. So it's not necessarily sold as a prescription, but it's something that you would go to, a pharmacy or a health food store to get. I think in Italy, Cytisine is not sold as something you would buy, kind of pre-prepared in a box with the pills, but you would have to go to a pharmacist and they would have to make it for you. It's one of those types of medications. And then finally, in Spain, I think the price is believed to be going down because the government's going to start subsidizing it. So again, those are all very different healthcare systems. What the cost is going to be in the US is unclear right now, but I am hoping that it is affordable and accessible for people. If you're interested in more reading on this, we've got some references here, and I want to thank the pharmacist that I work with, Emily Ware, who helped me prepare this presentation. I'm going to talk a little bit more about our tobacco treatment specialist training that we have at MUSC, but if you love a deep dive into how smoking cessation medications work and you want to learn more from Dr. Ware, that's a great opportunity. So thank you.
So again, I'm Eve Fields. I'm a psychiatrist, and let's click down. Up until February, I was working at the Department of Mental Health for 5 years, where I was the director of integrated care. And when I first started working at the Department of Mental Health and doing integrated care work, we decided to go ahead and do an assessment of what types of integrated care services were going on and what types of things were needed. And so we did this assessment, and one of the things that we did was look at the top diagnoses for the patients that we have. So for those of you who are not from South Carolina, and there are changes going on now, but has all of the mental health centers or community mental health centers in the state report up to the Department of Mental Health. And so it's a little unique in that there's this direct connection. So for all mental health centers use the same EMR. All of them have the same setup, and everybody reports back up to the central administration for that. In other states, it's much more regionally or state-driven, and there's not a shared EMR. So when we look at this data that we're looking at, this is for essentially the entire state. So it's a gold mine of data. So when we looked at this, one of the things that I had highlighted for us to look at was a tobacco use disorder diagnosis. And interestingly enough, when we looked at that, and it's up there, so I'm not going to ask you all, but only 3% of our patients were actually diagnosed with a tobacco use disorder. How many people think that's accurate? Okay, I'm glad there's nobody here who thinks that's accurate. And for youth, it was 0%. And in my mind, as a psychiatrist, I know that tobacco use disorder is more prevalent in behavioral health populations than in regular populations. And we know what the prevalence rates are, right? So we should be expecting those rates to be 20 or 30% or more even for adults. And while we have done great work in the state on tobacco, I didn't think we'd done such great work that our behavioral health population was at 3%. So what that led me and our team to think of was there's really a gap here between who's getting diagnosed with tobacco use disorders and who is actually smoking. And what that points to is a larger issue of not getting addressed, right? You can't treat somebody without a diagnosis, and that's really important. And especially as we're in the digital age, that specific diagnosis is a key for all kind of data gleaning that you might do in a system, right? How do you look at a whole population and see who's smoking if people aren't diagnosed with it. So that's when I became interested in looking at tobacco use disorder and what we could do, and started talking with some of the people in the agency, including Lamar Suber, who's there, who was working in the collaborative position with Deotis and Department of Public Health, and got involved with the Joint State Tobacco Group. I always think that's a little bit of an ironic name, but that was our group for that we were doing with, at the time it was DHEC, not DPH, Deotis, and the Office of Rural Health, and the Department of Mental Health. And I became really interested in this and started participating in these groups. And I will say that these meetings that we had, including other people here, Catherine Settergren, Helen Deckel, Katie Wynn, who's not here today, really was a highlight of my time working at DMH, because it was such a collaborative group, and it allowed me to learn about all of the great things that were happening here in South Carolina. And it particularly struck me as a problem that we had all of these great free resources, right? So most people going to a community mental health center have no insurance, they have Medicaid, or they're otherwise don't have a lot of things. So we have this free Quitline in the state for people, and yet we're not connecting them to care that they need. And so that to me was a real problem. So how are we gonna get people connected to care? That's important. So again, this is the group that we were talking in. And at the time, what was really nice is that DHEC had some money that they would provide to the Department of Mental Health for nicotine replacement products to bridge patients between when they were sent to the Quitline and when they would actually receive NRTs from the Quitline. Now, the amount of money that it was certainly generous and nice, but it wasn't really enough to buy NRTs for the 16 mental health centers and keep those in an adequate supply. And it would also require us to have mechanisms for distribution and all of these other pieces that were really difficult. And so what was also allowed was education. So we could also have people trained as tobacco treatment specialists and other things. And I proposed that we do a QI project. And particularly for any medical provider, you need something called continuing medical education credits, or CEUs. It's called different things on exactly what your profession was or is. And the other thing for physicians in particular is this thing called MOC, or maintenance of certification, which most providers, they have to do it to maintain their board certification, but it's more intensive, it's difficult to do. And my husband, who is a physician, did one of his at the last minute when he needed to on hand washing. And I thought, oh my God, if you graduate from medical school and you don't know to wash your hands, that is a really big problem, right? So I'm like, there's gotta be something better that we could do to help encourage people to increase their diagnoses of tobacco use disorder. So I spoke with this joint tobacco group, and they generously agreed to fund what it would cost to get this accredited. And so we went through all these steps. We designed the project, we applied for CME, we applied for the maintenance of certification. Those are two different steps. The money that we received from DHEC went to pay for the actual accreditation costs. We had to submit it, and it was reviewed by the South Carolina DMH IRB. And we received approval from leadership. We formed a planning committee, set dates. It took a lot of work. And basically what the project entailed, and at any given point there's approximately 200 psychiatric prescribers at DMH. We offered to do something that would include more providers, but we were told at the time, this is, again, in the pandemic world, everybody's overwhelmed, and so we don't want to add one more thing. So this was a completely voluntary project, and it was targeted towards prescribers. And what we did is we had them read an article it's called Tobacco Use in Mental Health, a Wake-Up Call for Psychiatrists. This was an article that I had seen when I had attended a CME event many, many years ago, and it was a CME event on tobacco use disorder that I really changed my perspective on treating tobacco use disorder in a healthcare setting. And it was a very short article. I knew we have limited time. We want people to get something that's going to be valuable. So it's 3 pages. And then what we do is we had data reports where each prescriber got a report of what their individual rates of tobacco use disorder diagnoses were for their adult population over 18 and their child population. And we had them compare that to their center, to the state overall, and to the prevalence rates of South Carolina, and then answer a few other questions about their practices with tobacco use disorder. And we did this 3 times, separated by 6-month intervals. And these are the results that I'd just like to highlight. So again, we had a total of 35 prescribers participate in the project. And again, this is about around, at any given time, 200 prescribers. And if you look, the light pink is the participating prescribers, and the dark pink is all the people otherwise, so about 160 or so prescribers who didn't participate in this project. So again, it was voluntary. You had to participate in at least 2 out of 3 to get the maintenance of certification credit. And what this shows here is, at the 3 different phases, what were their total patient population that was diagnosed with a tobacco use disorder. And I say we were generous with our tobacco use disorder. It could be that somebody was in sustained remission from a tobacco use disorder. But why is that important to recognize? Right? You want to recognize that because people are vulnerable for relapse. And if you don't know that somebody has had a tobacco use disorder, how do you know to look for that or address that when there are other things that are going on? So we allowed any tobacco use disorder diagnosis. And so you can see here in phase 1, and for the youth, the numbers are smaller, but this includes all youth 0 to 18. We don't see a lot of 3 and 4-year-old tobacco use users. So you can see here that in phase 1, the participating providers, in general, had about the same rate of patients with a tobacco use disorder. But after phase 2, that jumped substantially. So we went from just over 0.5% to 3% for the people who participated in the project, and just 6%, 0.6%. And again, that maintained for phase 3. For adults here, it's like a tripling effect, where the people who did this project probably were more interested in recognized tobacco use disorder to begin with. So we have a little bit, right, there is a discrepancy here, but their rates overall tripled over the course of the project. And data is important, right? That's really important. But the thing that I found most encouraging about this were, in the free text comments that we had people do, were the number of providers who said, wow, I really had no idea how important this was, and how when I would bring this up to patients, I actually had patients who responded and were interested in quitting smoking. And I got 2 patients to quit during the course of this project. And the idea is that they're going to think about that and address that, and that it doesn't have to take up the entire session. For people who are worried, well, I have this patient who's schizophrenic and just got out of the hospital. Well, if they're on Zyprexa and they just got out of the hospital where they weren't allowed to smoke, and now they're outside and they're smoking again, that Zyprexa might not be effective anymore. Like, these are important things to address and to recognize, and which save money over time for our whole hospital system and state. And so the importance of having people address this, really say that it changed how they practiced and how they thought about things, to me was really invaluable and encouraging. There were some people who think, well, when you're not doing this project, is it going to be sustained? In my heart, I believe that people who enter the healthcare field want to do the right thing and want to promote people's health. If you're here to make money, you entered the wrong field, right? You should have done, Wall Street or something else. But people want to do something, and they want to encourage health. And tobacco use is one of those conditions that affects every single profession in the medical field. There's not an organ system that this doesn't affect. And for people with behavioral health problems, it's extremely important. And for many of them who are living on limited incomes, it's a huge part of their income as well. And people don't want to smoke. They want to quit, but nobody's told them how. And the last thing I'll say about behavioral health populations is, for many of them with severe and persistent mental health issues, the only doctor or NP or PA they see is the one at the community mental health center. Many of them don't go to see a regular primary care provider, so we are by default their provider. And when we don't address big issues like tobacco use disorder, that's a problem. So this is just the raw data that I included up here from what we did, in case anybody's interested in that, but I think the graphs are better at explaining that. And that's just one of the references I had. But thank you for your attention.
Dr. LaShondra Morgan from Breathe Easy, South Carolina. I would like to thank you. That was really good information. I want to underscore something that Mr. Lorenzo said, and I have a question. I want to underscore what you said about how when teens get in trouble for tobacco use, they get suspended instead of going through some type of education program. Throughout the state, we've noticed that students of color actually get harsher punishment, sometimes even getting expelled. So I just wanted to underscore that. But my question is, wrote it down. I'm a fellow data geek. So do you track like where your referrals come from for the Quitline? And do y'all have that by zip code? If so, do y'all share that information?
We probably could. We'd have to take out some of the PHI and make it de-identified. But yes, we get referral reports every month by facility, provider. We have all that information available.
Yes, to piggyback on that, give us an idea of the numbers of participants that you have in the under 18 digital program in South Carolina.
So I'd have to look at the dashboard, but I just looked at the pregnancy one too. I wish I'd have looked at the youth. I can speak more so on the Live Vape Free numbers, which is ramped up. We just did like a social media campaign, so that really exploded the numbers. But I would say less than 100 per year in 2024. I know we had like 106 pregnancy participants, but American and Indian youth are usually our two smallest numbers. If I remember correctly, and this, for some reason, this number pops in my head, but it's 67. I'm not sure if that's American Indian or youth, but it's definitely less than 100.
So there's a lot more we can do to push that.
For sure. Now, like I said, they're more prevalent to go into the Live Vape Free program because we do a lot more marketing to youth and young adults, because that program is ages 13 through 26. So 13 through 17 is for youth, and then 18 through 26 is young adult. That's how we kind of identify them in that program. But yeah, we get a lot more numbers in that program.
Thank you.
Yeah.
I had a question that might go towards Amanda. I know you mentioned your tobacco treatment specialist training, which is great that you offer. I know there is a registration fee. I've worked in other states where they offer that for free, which is amazing. Do you guys offer brief intervention tobacco training, though? I know that's a shorter training that's usually offered for free and helps physicians better discuss tobacco. I have found, sorry, I'm with the American Cancer Society. I found that sometimes the issue is, right, as providers being able to have these delicate conversations with a patient. How do they talk about it? They may say, here's just a Quitline card, but really a motivational speaker, and then being able to motivate them and have the resources. So anyways, is that an option? And it may not be just towards you, but if anyone else on the panel is aware that that's offered within the state.
Sure. Again, I was going to talk a little bit more about our training at our next talk, but I will mention again, it's a really comprehensive training. It's 4 days long. If the cost is prohibitive for you, email us and let us know, and we can definitely work with you on that. We've done that for people before, because I understand that it's that can be a barrier. I think that's a great point, that a lot of providers maybe don't have 4 days to spend getting a lot of specialized training and maybe need a briefer training. It's not something that we specifically offer, but I imagine that there may be resources available. I'm not sure of any off the top of my head, but we've got some other panelists here who probably have some information for you.
So my colleagues over here that you're just talking to, that's our bread and butter, brief tobacco intervention training. So we'll come in and we even buy you lunch. So not only is it free, but you get free lunch. But that's really our bread and butter. We'll go in, sit down with providers, obviously give them the resource and educate them on the Quitline, but really go into that brief tobacco intervention training so they can talk to their patients in a motivational way, not talking down to them, So yeah, we get a lot of good feedback from that.
There's no tie-in that they have to do like the EHR thing, the Quitline. It's just they can just use it as an educational piece.
Oh yeah, and of course, like I said, we give them the resources to refer patients to the Quitline, so fax referral. If they want to go the EHR route, we can set them up with that. A lot of times it's a little expensive, so they kind of opt into the fax or online portal, but yeah. link up with him. We'll go anywhere. Yeah.
I can validate that that's what happens. You can have them come in, they give a free lunch, everybody likes a free lunch, and then they show you all about the resources and how to, connect patients to the line, whether it's giving them a pre-printed tobacco, prescription, or you fax referral to them. And then they communicate back with the provider too about whether they were able to contact them or not.
I'm a part of the Pickens County Youth Board, and we just had a vaping conference about this, and I was wondering if we would be able to use y'all's Quitline, like print things out for it and share it among them, if that's like something we're allowed to do.
Yes, ma'am. We have a lot of materials that are available because we go to a lot of conferences and stuff. We're even able to make new stuff, maybe tailor them a little bit to what you're trying to do too. So yeah, we'd love to accommodate.
Okay, thank you.
Thank you. We have a question over here.
Yeah, Mike Cummings from the Medical University of South Carolina. So to the panel, what's innovative? Cytisine is innovative. It's new. It's coming out. Varenicline was our last stop smoking medication. That was 2006. So 19 years. We don't have 19 years left. So combination therapies, I didn't hear mentioned. I mean, just trying to get them to assess tobacco use disorder, which is pretty complex when I look at the diagnostic and statistical manual, and it really comes down to daily use of nicotine products that probably is triggering who's dependent on nicotine. Nobody mentioned e-cigarettes. Amanda, you're doing work on oral nicotine. I know there are studies that are going on combining like varenicline, cytisine, and yes, even some of these recreational tobacco products that don't create smoke. How do we reduce smoking? Because I see the trends, and the trends show that kids have given up cigarettes and they're vaping. That's a win. It's not perfect, but compared to my generation of Marlboro smokers who are our lung cancer patients today, that's a win. And how do we get rid of the smoking in our older smokers? They have to be a priority. Heard nothing about lung cancer screening. We try to get them screened. But that's a high-risk group. That's easy pickings right now to do something. What are we doing with that, Sharon?
So I can just say across the states, they haven't really embraced using e-cigarettes yet, but I don't know that that's not something that will be looked at within the next administration. I think they're going in a different direction. There aren't a whole lot of novel ways to do this. So just trying to, but I don't think also that we fully implemented the evidence-based strategies that we know work. So really trying to get all of our providers to address tobacco use and in a preventative way, not necessarily when they come in for lung cancer, but when you come in for your routine physicals as you're aging, as you're getting older, to make sure that your primary care physicians are asking, to make sure that we are asking in ways that are culturally sensitive. So because we know that the demographic populations are different and the way that they hear those messages are different. So really trying to make sure to implement the things that we know work and then look for new and novel ways to try to encourage those, especially those hardcore smokers that are so difficult to change.
What people are using, because they're not using varenicline
Hi, everybody. Fantastic information so far. My name is Rajiv Mavath. I'm the new or relatively new Director of Surveillance and Evaluation with the tobacco program. I took over from Dan Kilpatrick, much to the regret of my fellow colleagues at the tobacco program. But jokes aside, my question is to all four of you about educating the providers. That has been one of the big things which, like driving the referrals, the education piece. And I wanted to ask one directly towards you, Dr. Fields, as well as the second part is to everybody else. Dr. Fields, one of the things with physicians and anybody else is they talk with each other, like what's working, what they're doing. Was there a follow-on effect after this QI project where you saw other providers like start to do the same thing as the first cohort? Did you see an uptick of that? And to the rest of the group, one of the things I happened to accidentally find out is that among medical residents, only 40% were asking tobacco-related questions to their patients. And how do we improve that as far as education goes, not just to those who are training, but also those who are also already established? Thank you.
Thanks. So just to answer your data, when I got that initial report that said only 3% of our patient population was diagnosed, we started tracking that and getting monthly reports on that. And what we did see, and I would bring this up in meetings and talk about the importance and talk about I mean, to be honest, most providers didn't know that there was a free Quitline in the state. Just understanding that that was there was something that was important, and giving them access to resources and reiterating it. So before I went to medical school, I worked in advertising. People have to see things 7 times before it really hits home. And I can't reiterate this enough, and maybe I should do it 7 times, but seeing something over and over and over again and from multiple different sources is really important. So what we did see was that the rates increased, I think, to about 11% among all patients, and that was not just driven by the people who participated in the project. The other thing, I think, is having champions or having people that they can turn to ask, because a lot of them are like, well, how am I supposed to do this? How am I supposed to bring this up in a clinical appointment with somebody? And I said, it doesn't have to take up the whole time. Whenever you see somebody, you ask them about their tobacco use. Are they thinking about quitting, would be the question they would have. And if they gave me a hard no, I wouldn't push it, but I would bring it up. And a crystal example for me is one patient who said, God, my primary care provider keeps telling me I should quit smoking too. I guess it's really important. And I was like, yeah, it is really important. And so I think just having that there, having there be a culture in the place where you work that wants you to look at that. There are quality improvement measures in healthcare. Some of them are called HEDIS measures. I don't know how many of you are familiar with that. I personally think that there should be one for, does your rate of diagnosis of tobacco use disorders match at least the prevalence in your community, unless there's some, you work with a very specific patient population. But we should be diagnosing it even if it is in sustained remission. This is a chronic disease. The people that I know who are former smokers, even 20 years out, will say, if I walk by somebody who's smoking, I'm triggered. I want a cigarette, right? We need to encourage people who are quit to stay quit and to celebrate that with them. I think people go to the doctor and they're afraid of all the negative information and all the things they're gonna do that are wrong. What if we actually said, wow, you've quit for 10 years now? That's amazing. How did you do that? You walk away feeling good that you've done something good about yourself. So I think we need to turn this around too and really give people credit for the health changes that they have made, and to encourage providers to address these things in small ways. It doesn't have to be huge, but it's that persistent, doing it over and over and over again, and knowing that you're part of a system that's doing it over and over and over again that makes a difference.
Another barrier that I see that I think we really need to do more work in addressing is the perception that providers have that their patients don't want to quit. They don't want to hear about it. It's going to upset them. It's going to damage their rapport. I think a lot of people, again, might be sort of afraid to start that conversation, or they think it's just not worth their time. Like I've had even some of the psychology interns I work with, they say, well, they've got bigger things going on, so I get why they don't want to quit right now. And, I think that perception needs to change. I think most people that are using nicotine and tobacco products do want to stop or do want to reduce. There are lots of, aside from the health outcomes, there are a lot of negative consequences to their use. So most people probably do want to change. But I think that being able to have that conversation, again, be trained to do it in a way that maintains the rapport, that keeps it, positive and strength-based, and also offers options, right? So not just scolding people for using tobacco, but, telling them and understanding and empathizing that it is a really hard behavior to change. And that there's different options. If you don't want to, just quit right away, maybe there is an option to try reducing or to try switching to something less harmful. So, meeting people where they're at and having that conversation can make it go a little bit more smoothly. But I think at first, providers need to believe that people are open to that conversation. And in my experience, most people are, but the perception is that they're not.
That's a great point. Going back to the brief tobacco intervention training that, our team completes, we touch on different things. 75% of tobacco users want to quit. So it's kind of going back to what she says. And then we always say, we don't want to just sit down with providers. We want to sit down with the whole clinical staff, from the MAs, reception, everybody. And, we always say during our presentation, if everybody who sees a patient during the visit at every time mentions, tobacco cessation, it would reduce tobacco use by 20%. It might seem like a small number, but that affects so many, millions of people. So we think it's important. We touch on that a lot. And you'd be surprised how many providers are, I've never heard of that program. It's a free program. They do commercials all the time. But we run into that a lot. So it's very important. People want to quit. It's just really giving that motivation, that repeat, like she was saying, repeating that and making them hear it and understanding, and then having them think critically on why it's important. So with that training, you don't just talk at them, it's motivational. It's like, tell me why you think your health would, improve if you do quit. So, you have their different diagnoses or chronic diseases, let's refer it back to this, what's going to improve, and just really understanding that the effects happen immediately. So we have a chart that we'll bring up during the training that shows within minutes, your CO2 levels return back to normal. And it goes all the way through 20 years. So it's not like, oh, in 5 years you'll see, health effects. It's within minutes. So we think that's important. But just getting out and reaching as many physicians and clinical staff as possible, that's been our goal for the last, 10 years, y'all? And I think we've done a pretty good job, so.
And I'll throw in, too, that it's important not just to get to the providers, but to get to the whole health system. Because if you can integrate it into the workflows and make it a routine standard of care to be able to address tobacco use and have the advice to quit and then referral to either the Quitline or local services, that's much more sustainable than just going provider by provider. And to that end, NACDD is working on developing competencies for staff members to be able to work with health systems. So what competencies do you need to be able to go and work with the health system to be able to offer a change to integrate tobacco as a standard of care, tobacco cessation as a standard of care. So we are working on that. From the medical school standpoint, there are already competencies that are part of a medical school training that are specific to tobacco cessation. And so just really emphasizing with our medical schools to make sure that they're using those competencies to be able to have providers coming out of medical school that already think about tobacco cessation as they begin treating their patients. And the last thing I'll say is an opt-out approach is really the best. So to get those health systems to adopt a system where they ask every patient all the time, like it's a routine part of what they do. It's not that the provider decides one way, well, I'm going to do this or I'm not going to do it. If you do the opt-out, then everybody does it, and it becomes a standard of the healthcare facility, and then you know that all of your patients are their tobacco use is being addressed and that they're being offered resources.
One last thing. for patients who may not be ready to quit right then, we will leave, brochures or have providers and their offices order free materials from the Department of Public Health for leave-behinds that, provide education on the program that may motivate them. And also, we have an online training that we'll leave behind as well that we got accredited and we'll give CEU credit. So we really promote that within the office as well. So new staff, there's a lot of turnover, they can complete that, learn information, and just kind of keep them motivated to address tobacco use within their offices.
Good morning. I'm Dr. Yvette McDaniel with Breathe Easy SC in Orangeburg. A couple of observations and questions very quickly. Many of you have collected data. How much of that data is geared to parents who are ashamed for their children to be smoking, more or less vaping? Are there specific studies that have dealt with or specific interventions that are being put into place? We are dealing, those of us who are boots on the ground, with the problems in vaping, not the positives. We are dealing with third graders who not only have vapes, but have marijuana or THC in their vapes. Have we focused our data research on those people who are not being served by vapes, but who are being predatory practices that are done, and then the parents, guardians, or those kids themselves being surveyed for them to be able to deal with the mental health resources, the quit resources? Are we studying that? Are we addressing that? The positives of vaping are the positives of vaping. But when you get a third grader who is going to get 100 cigarettes worth of tar nicotine with one vape in their third grade, are we dealing with that?
I'll touch on that just for a second. And I have a second grader, today was his last day, so he's going into third grade, and I swear if he ever thinks about it, there's gonna be a problem. So I can't really touch on that, but I will say for adults, like parents, guardians, anybody within schools, anybody who's in a youth's life, we have the adult advocate program through Live Vape Free that they can sign up for. And it's not, not different lessons they have to complete, but basically it's educational materials on how to be a champion for a teen and talk to them in a motivational way instead of, kind of like I do sometimes, harp on your kids and talk down to them and, punish them all the time. But so it really gives you tools on how to understand what vaping, the harmful effects of vaping, what they may look like, because there's so many different devices now, you won't even know it. And just, really educating your teen and helping them through the program if they sign up, just making them understand that this is harmful. These are some of the harmful effects you need to know about. And, I'm not trying to get on to you, but let's get through this together.
And I'll share too that this isn't a group that I personally work with, but at MUSC we have a group called the MUSC Youth Collaborative, and that's a group that works very closely with community organizations like yourself. So they would definitely be interested in working together. They also work with schools and PTAs and pediatricians, but they do a lot of sort of prevention and education and treatment work around things like youth tobacco use, cannabis use, and alcohol use. So that might be a great resource for any of you who are interested in working with them.
So again, my name is Rajiv Mawat. I'm the director with Surveillance and Evaluation. So to answer your question, yes. Where are we doing it? We're looking at two particular locations. One is the Youth Tobacco Survey, which we provide to the high school students in South Carolina. and also the adult tobacco survey. That's the 18 and older, non-institutionalized adults. So we have specific questions that are asked on these surveys to the people who are responding to them. One particular part is like the rules that the kids are facing. Do they have smoke-free rules at home? Do they have smoke-free rules in the vehicles? And also among adults, the same questions, but also do you have it, do you experience secondhand smoke or exposure to tobacco in workplaces or public places? So those are some of the places where we get direct responses from our respondents from South Carolina. The second thing I want to also touch base on is we asked the impressions that the kids have about smoking and vaping. One is, do you think that tobacco is considered cool? Or if tobacco or vaping, people who engage in cigarette smoking or vaping have more friends. So those are, again, information that's coming to us directly from our communities. Then what we would like to ideally do with that is take that information and go back to our schools, our parents, as well as the students themselves, and be able to give them the education. Because one thing that we're starting to see in the trend is there is a real window of opportunity where we need to be looking at, I can't speak for the before middle school because I don't see that, but definitely during that period up till about 10th grade, that is really our window in which we need to educate our kids. Also, the other thing I want to make sure is like well over 85% of the kids are saying parents don't allow smoking in their car, in the vehicles. Well over 95% say that they don't allow smoking at home. These are the kids talking, not anybody else. So essentially, the parents are obviously do not want their kids to do this. But where are the kids getting it from? That's another set of questions that we get from these particular surveys. One is from their friends. Well over 48% are saying that they're getting it from their peers or people that they know at school. Then another thing is they're getting, another 45% are saying that they are getting it from the community stores, maybe gas stations, or some convenience store that's relatively close to the school. So essentially, you have business owners who are not doing their due diligence to make sure that the ages are being verified before they're selling. So we're starting to see that a lot of the influences are coming outside of the home. So it's, again, how do we educate the parents in order to get that message, hey, we understand that you do not want your kids to smoke or take have anything to do with tobacco. But unfortunately, they're being bombarded from the outside of your control. How can we set up things in their various locations, whether it's schools or in the community? I mean, do we educate a parent to say, hey, we know such and such community or gas station is selling, is one of the sources for tobacco products. Essentially, you do like almost like what has happened with some of the places like Target and so on, where people have made vows that we're not going to spend money there. Create that economic pressure on some of these locations where it forces them to say, yeah, okay, we're losing money and customers because of this. Let's do a better job of it. So is it perfect? No, because number one, the youth tobacco survey is done every other year. Now it's going to every year. And the adult tobacco survey, it's also, it used to be every other year. Again, we're going to more of an every year. But it's dependent on the number of people who are actually responding. You know, that's a problem. We needed a minimum of 37 schools for our 2024 YTS. We got 19 schools that took part. We needed X number of % of adults from around the state of South Carolina that needed it. needed to conduct to like reach a certain sample size, we did not reach that. First, we were doing through telephone, like random dialing, but who uses their landline anymore? You know, now we're going to address-based. So we're trying to find these ways in which we can get better information on a regular basis, more real time. We tend to have more, if like we have access to the cessation or the EMRs or whatnot, but on the purely surveillance side, this is the problem that we're facing, is we are trying to make, find out about our trends based on these responses.